Good afternoon, everybody who are following our so-called coffee morning. But yeah, I don't know why we call it coffee morning if we have it in the afternoon. But anyway, hopefully you have all grabbed your coffee either now or in the morning. And today we are talking about healthcare and care with distance spanning technologies. And we are delivering or introducing really practical and clear examples from Norway and Estonia. And the good thing is that actually people who are using or would love to use distance spanning technologies in their work will give their opinion and view and their view of point of view to these solutions. So we have 2 presentations from Norway and 2 presentations from Estonia. The duration of the webinar is approximately 2 hours, and please, you can also actively get involved in and you can ask questions from the presenters. Under this event, you can see the link or drop your question there, and I will ask the questions from the presenters. So first 2 presenters we have from Norway. And the first presentation is, now you have to excuse me if I pronounce your names not correctly, Tor and Ranveig from Helsin. And Helsin is a cluster organization working to promote co-creation and innovation processes for better public health and more sustainable health services. The cluster has approximately 50 partners organizations from the public, private and voluntary sectors. So please, Tor and Ranveig, the stage is yours.
You're live. Put your microphone in. Det räcker med det.
Can you hear me? Har vi begynt nå? No. Gir noen beskjed når jeg skal snakke? Hello from Norway, and thank you for the opportunity to take part in this event. We look forward to learning from you and to sharing some of our perspectives on distance spanning technologies. My name is Ranveig Finnsveen. I'm a research and development advisor in Helse-Inn, and I have my colleague Tor, advisor for digital transformation, on my side. I will start saying a little bit, a few words about Helse-Inn and how we work. And then Tor will present healthcare with distance spanning technologies and highlight some challenges, opportunities and solutions from our Norwegian perspective. So Helse-Inn, which we are representing, is a non-profit cluster based in the inland region in Norway. we are working for better public health and more sustainable health services. Our office is in Elverum, which is about 2 hours north of Oslo. And we also have premises in Gjøvik. Helse Inn consists of 52 partners. They are from public sector, research and education, private sector, and also civil society. And we differ from a traditional business cluster as our public sector partners, which means our 14 municipalities, or the Inland Hospital Trust and the Inland Dental Service. They all have an active and prevalent role. We also differ in the way NGOs and other organizations representing patients, such as Kreftforeningen in Innlandet, are involved in the partnerships. 22 of our partners or members are private sector companies. They have a varied profile, and some of them are based in the inland region and some from outside Innlandet, but working in a national or international market. Based on this partnership composition, our main endeavor is to connect the needs in the health sector with solutions and competences in the private sector, and together to cross-sectoral teamwork based on user needs and co-creation, improve health services. We believe that this approach creates value, both for the companies involved in our partnership and also for the society, and the latter being a very important part of, and somewhat the DNA of Helse Inn. So, nå kan du skifte. What do we do and how? So, what do we do and how do we work in order to create further ground for cooperation and innovation? We invite our partners into different events and arenas. We offer InAgent, that is a cross-sectoral competence program in innovation for our partners, and we have a needs-based research and innovation accelerator, which is a systematic framework for establishing partnerships for research and innovation projects. We also have a lab demonstrating different solutions for the health sector, and a creative problem-solving lab called Lab for Integrated Healthcare. The labs are available for all our partners and members, and we there facilitate activities and workshops. On the agenda in these labs, we often have the questions relating to e-health and distance spanning technologies tour. And please, I give you the floor to dive further into this topic and say some about solutions and challenges from your perspective.
Yes, I will take it from my point of view. I'm glad to be with you. I would be even happier if I could go to Tallinn. I used to go to Tallinn with my wife for a long weekend each year, but we can't do it now. So I hope to get the possibility to meet you there sooner. This time I'll start with the benefits of smart use of distance spanning technologies. What are we going to do and what do we want to realize with it? Yes. The inhabitants may stay safe at home longer and stay at home in situations they earlier had to be in hospital. That's a big goal. It's a very benefits that we are working towards. When we are less dependent on moving all the patients to hospital for monitoring and diagnosis. Less transport saves the patients for discomfort, and the society saves a lot of money. And we can use expertise more efficient. And if we use technology in a smart way, we can facilitate collaboration between everyone involved in the person. I think that is the main reason I'm working with technology. I'll take you back in a historical retro perspective. Back in 2005, it was a Depositive report that said, already today it's possible to start investing in preventing measures and initiate measures related to knowledge, new technology, buildings and systems. This was in 2005. In this way, all inhabitants will be secured the opportunity of living meaningful and independent lives in spite of illness or loss of functionality. That is the reason why I'm working with this technology. And we started already then. Since then, a growing number of health services has been delivered where people live their lives daily. And we use technology to create closeness between people and the services in spite of physical distance. We use technology to support interaction between all the available resources, different parts of the health services, relatives and volunteers. We have to do this together. And in Norway, I think we started with the alarm services. The digitalization in alarming was the start of the whole working. And then we put more and more technology into the homes, and we are still doing. But after a while, we had to see the whole of the ecosystems and the big context. And we had to solve this major task together. The response services are the main working area, I think. It's a big work to do there, to get this together. And it's possible with technology, I think. We knew it. Everybody was talking about it, but we did not really understand the impact, I think. The largest share is all about organization. Technology creates opportunities, but represent only a small element in the solutions. The technology must be combined with services. And in Norway, we established the National Program for Implementation of Welfare Technology back in 2013. I think, but this affected only the municipalities. And from my point of view, I think in the start, the focus was on the devices. But now we are switching the focus from technical devices to organizational reconstruction and new services. And the goal is overcoming organizational barriers and institutional lock-ins. I used to say that the program has grown out of its silo. We are now talking about digital transformation in a larger context. And so the hospital is arriving in the area. Medical equipment is moved to where the patient is, not the other way around, as we has been doing for a long time. A different management level is at full speed into the municipality's domain in Norway. It's like this right now. To give you an example, they are planning a new hospital in Innlandet, 20% fewer beds, because we think we have to do the treatment in a different way. And the 20% is going home. And then the various technology and services meet where people live. And the inhabitants' home becomes an area for different service regimes. And the basic premise for cooperation is to use the same information. And I think we have to share the technology as well. This is a big issue in Norway right now. And to do that meeting in a good way, it is established health communities where hospital, municipality and doctors come together to provide comprehensive services. We are starting talking with each other. That's a good thing to do, I think. From my point of view, the needs more focus. Digital devices consume and produce data, and the data is the real value in this. And we have to take responsibility for the data. It's a lot of data in this field, but a great lack of information, I think. We need to share data throughout the healthcare ecosystem. It's absolute necessity to share data if we are to provide comprehensive services. This is from a survey made by the Norwegian Directorate of Health. They asked about drivers and barriers for innovation in the primary health sector. And this is what come out. Number 1 was economic flexibility. 2 was culture. I say I've done the numbering wrong, but that's okay. Legislation and anchoring. This is big barriers and primary for the innovation, I think. And they asked the hospitals and they asked the municipalities, what are the main challenges related to rapid implementation of distance spanning technologies? And as you can see, it's a different picture if you see it from the hospital perspective or the municipalities. And this is why we need to talk together to get the same picture so we know what to do. This, I think, we have to give attention. It's difference in culture and perspectives. From the municipalities, 68% declared a need of better coordination with the hospitals. And in the hospitals, only 29% say there is a need for better coordination with the municipalities. I think it's a very, very big issue that we think about this. We have to coordinate. Which national measures are necessary? The answer was this: national recommendations, national financial support, and common processes and routines for the system integration. This is the top 3 of that. But let us focus on the needs. What are we going to do? The complexity is so big that we are never getting further if we only look at this. What have we of tools to do this? And in Norway, we are doing a lot of projects, so that's good. Let's focus on that work. Examples is patient-reported data. The patient is active involved in their own treatment, doing the measurement at home, doing it themselves. It's very good. And a very exciting sensor, I think, from Omsyn is a little sensor. You can put it in the bed. And this is monitoring critical functions without active involvement for the patient. And related to AI, we can predict serious conditions as heart attack, epileptic seizures. And these solutions have already saved lives of several COVID-19 patients. I thought I should show a video, but I dare not. But we are doing a lot of projects with the head cameras. Use voice control head camera for ambulance personnel, pre-hospital video communication, which is very powerful. And we also work to connect the home services with the hospitals. And we have examples: wound treatment without moving the patients to the specialist. Home care providers use advanced cameras and transfers pictures of wounds to the specialists at the hospital. And they get the advices from the specialists. So I think this is taking us into a new future. Using smart glasses used by the home care providers, voice control. They have 2 hands free to do the work. The specialist in the hospital or a doctor connects to the patients through technology. The different services providers have to access the same data, sharing the information using digital instruments. And this is what we are doing right now. We are trying to use the same equipment with different service providers. And this is a very big opportunity, I think. So this is what I wanted to share with you today, just a little from the overview, and thank you.
Thank you for the presentation. So I have one really quick question. You tackled a really interesting mismatch there. So the question is about how the municipalities and the hospitals see this need of communication and collaboration or coordination differently. You said that most of the municipalities think it's needed, and also you said that only 29 of the hospitals do think that it's needed to coordinate these activities. So my question is, like, how you tackle this issue or how you work with it? Okay, then we move on with the next presenter. I will ask this question later. So our next presenter is Jens Espeland, also from Norway, and Jens is general practitioner, and he's also a public health officer in the Sarpsborg municipality in Norway. So Jens, the stage is yours.
Yes, hello. My name is Jens Espeland. Thank you for participating in this event. It's a privilege for me.
What the fuck? Mikrofon väljast tal või? Räägi või tal ei ole midagi kuulda?
For remote care. And I worked for 10 years and now I'm a public health officer in a municipality in Norway and have some 10 years as a chief medical officer in Dignio. So my background and my experience is from working with developing most of the methodology in remote care and how to adapt technology in a simple way. And how could we use this as clinicians? And the biggest challenge has been how to think simple. It's a lot of extremely advanced technology, but who need the most advanced technology? Tor says something about it. We have used advanced technology for a lot of times, and the emergency care needs it, but we have worked most of the municipalities. So I just to share some from a clinical point of view. So this is not. Yes. I just start with the first thing was I think it's important to point out we have to see on the general principles in clinical patient work and have a generic approach to use digital remote care and digital treatment. We have to see this is all thing about how to adapt the general clinical patient work methodology with use of digital equipment. So we have to think about how to collect symptoms, how to get the symptoms for the patient. The symptom is the base, or the basic from all consultations. If you don't have the symptoms to the patient, you can't do anything. The second is to support the symptoms is how to measure the vital signs or clinical examination. And a third thing is how to communicate. Without communicating with the patient, it's impossible to have a treatment. And this area should not solve everything. So think when we think in a work in a clinical way, we have to ask, why are we going to use this technology for the patient? For what and for how long? One of the problems in the municipalities is that it's a lot of enthusiasm of a new technology, and then we think this will solve a lot of problems. Sure, it will, some problems, but it's also important to see sometimes it doesn't fit, and sometimes it fits, and that's what the health professionals are good at, to adapt each methodology to what the patients need and what is necessary for the treatment. And I think also important is there's a lot of apps for diagnose-based apps, and I think that's not a good way to go, because it's so specialized, and then we run directly into the specialized world where we have one technology and one app for each diagnosis. And you could, if you search for apps for cognitive behavioral therapy, I think you will find hundreds of apps. So I think it's important to develop a digital tool for generic, and by following the principles I have told you, you can use the same equipment for following chronic diseases. You can follow treatment, you can follow rehabilitation and preventive care. But of course, you have to develop special methodology for each diagnosis and each diagnostic area. And my experience is from what we have developed and my clinical experience, if you working with this generic principles, it's a very useful tool, and you can combine different tools and different software solution together to solve this problem. And that's why it's so important to cooperate in the, like Health In, how to put this together. So you don't need just one solution. You need how could these different solutions work together. And I think another what's also very important is that often you see you have some apps and develop them, and secondary you develop a solution for the health workers, or the vice versa. You will develop a health workers a journal system, and then you develop an app. And I think if you go to have a functional system, you have to think both things at the same time. How these fit together, you have to develop them in parallel, because one of the problem is if you are focusing on just the patient app and not thinking about how will this work for the health workers, you will often get a bad solution for the health worker and a good for the patient, and vice versa. And I think that's will work. My experience is that will work, but it demands a lot of cross-competence work, not only technical and in developing competence, but also in clinical competence. And also it has to support clinical needs and efficient working flow. And how to prioritize. You have to get quick overviews, what you are required to follow up, what's important for the patient and what's important for following the diseases. And it had to be an overview of measurements, messages, etc., that provides a good decision support. And I think one of the most important things is design for good interaction between different actors involved in a cross-competence team and also with the patients. We have now seen our evolution in the video use, but I say video is not innovation. It's just taking the traditional consultation to a digital meeting room. But it's also the problem with videos is that you have to meet at the same time. And I think we have to introduce much more asynchronic communication as we do in all other areas in the society. We have to use that much more in the treatment and communication. You don't need to see all the patients all the time to give good treatment. And I think that the work tools for the clinicians, the key functionality in the clinical view, you have to have full access to the patient data and history, an overview of the patient, access to relevant information provides good decision support. You have to access to patient communication. They are easily accessible. It should be easy for the health workers and easy for the patient to have their communication. Now it's often a problem for the patient because you have it's the health workers who decide when you can contact them. And you also have to have an easy overview of vital signs and medical equipment and its administration. So it's not only to take the measurements from the patient, but you have how to serve the medical and learn the patient how to use it, and also how to administrate it. And that's a partly an unsolved problem in Norway. In a systematically way, anyway. And you also have to have a flexible system to changing vital signs, as we use in the clinical work, when you want to change, if you're going to change from pulse oximetry to blood pressure, for instance, and how to change what's symptom reported, and how to change task and self-management plan. My experience is that if the patients are very active in telling us clinicians that they have to change the follow-up, and they are very active in giving feedback to what we are doing as clinicians when they get full access to what we are doing. And I think it's also, we are very focusing on the smartphone and the Apple smartphone, and that's very good because it's flexible and portable. But I think it's also important to think that for some patients a tablet is better, and for some patients the PC is better. So it's very important that we have the flexibility to adapt the system for the patients in all these kind of solutions. What about the patients that then? I think one of the most important is it should be very clear for the patient what is the daily tasks the patients are going to do. How often are they going to measure the blood pressure? How often are they going to take their blood glucoses, how often are they going to, how are the self-management plan to treat it, how to when they get the different values. And they have it's important that they experience close healthcare connection, both via chat and video if necessary. Some patients said to me that we have never experienced so close relationship to health professionals as we have after we get remote care. Before it was a far more distance to the health professionals. And it's also what have been the most challenging way thing in the development of the methodology is developing a good self-treatment plan and how the patient are going to follow it. So it have to be a system which is clear. It tells the patient what they can do by themselves, like diabetes patients who daily are treating themselves. There's no logical reason why other people can treat themselves like diabetes patients. And it's also very important they have access to their own data and history. It's important not to hide some data because if we hide the data from the patient, they get they miss important information about how to deal with their own disease. And my experience is if they get a good overview, our journal notes are accessible for they to read and to comment on. It's a great pedagogic task and help them to deal with their situation. And I think it's important to have a good methodological and clinical approach and together with the patient. We often, as doctors, say we are responsible for designing and the goals, but if we don't do it together with the patient, I think a lot of experience you other guys have is that the patient doesn't follow it if they don't believe in it. So that's about what I told about. It's about reporting symptoms and change what symptoms are different from different phases of this of the disease how are they going to measure the vital signs? What tasks are they going to do? How are we a plan for how are we going to communication? How often? What are we going to talk about? How to get the expectations to another? How often? And how are we developing the self-treatment plan? And I think that the system have to make it possible to have a function-based mapping and diagnosis and function-based method. And you have to think individual. By using remote care system, you are not. It's not a research program. It's a clinical treatment and follow-up. And you can use also validated questionnaire at the same time as you can use individual questionnaire, which is adapted to the patient. And my experience was when we made a good routines and procedure for the treatment and follow-up, it was easy to follow with a good system, which was very efficient for following the patients. And also the same for communication and self-treatment plan. Self-treatment plan is a problem to develop because it's more complicated and it's necessary for the cross-competence team to get access to the treatment plan. So that's need that there are some communication between the different systems, and that, as you know, is one of the great problems in digital work in healthcare. But I think it could be possible. It's possible in finance, and with the finance are years ahead of us. And I've asked, why isn't it possible in health? And I haven't get a good answer yet. And you know this quality circle as academic circles, as you all know, I think. And what's my opinion on was critical to the clinical implementation? And that's based on my experience, and it's based on my contact with a lot of communities and municipalities during a lot of projects. And when I'm now working in a municipality myself and with organization, I think a customized organization is important. I see a lot of municipalities choose different organizations to customize the digital follow-up. I think they have to, and I think that each organization have to find a way how to customize it and work on that, and have realistic goals and have clearly communicated routines and close follow-up by the immediate manager is extremely work. It doesn't help if the top leadership go for it, but if the immediate manager don't believe in it, it's almost impossible. And interdisciplinary collaboration are extremely important, and often a problem, and individual adaptation. And I think a lot of people ask for the diagnostic procedures, but I think if you use the system, I think individually, it will fit much better into the general clinical way of thinking. And as I said, a dynamic self-treatment plan. That's the problem is it's a lot of work, but I think when we are going to use digital remote care, it's not about having to do less, but it's how to use our competence and experience in another way. You can see. And one of the biggest problem was how to motivate the patients. If the patients are very sick, they are easy to motivate. But how to motivate patient, for instance, in preventive care? Our experience by following about 50-60 diabetic patients, the long time sugar level was improved for almost everyone, and they 60% changed their activity and their diet. And I think when we talked to the patient, I think the succeed factor was that was the right patient at the right time, and they were motivated by this methodology. Because we have tried because heart diseases, where there was a low rate, and that was because they weren't motivated. Are there any shortcuts? I don't think so. But if I'm going to point out the three most important tasks, is these three. It's to customize the organization, have small, and it doesn't have to be small, but anyway, realistic goals, and focus on the immediate manager. Last slide. We always like patient history. I think for all of us, we want to ask the patients as this Mona, who have used this technology for a lot of years, says in the newspaper here in Norway. Now I have better control of my COPD disease again. it means a lot to me. At the same time, it also means a lot to my family. They do not have to worry so much for something to happen, she comments. And she was in hospital about 10 times a year before you used self-treatment by remote care. And when she used remote care, she almost never at hospital and treat herself and have a close connection to the family doctor. So this was my experience from the clinical point of view for these years, and I'm looking forward, and I think it's very important that we have such arenas as this, because I think the success depends on how we manage to cooperate and think of a new way of not building our own silos, and how the companies and the public health sector could managing to cooperate. Thank you very much for your attention.
Thank you, Dr. Jens Espeland. And the next presenter is from Estonia, Dr. Eero Merilind. He's a family doctor and the head of Estonian Health Foundation. So, Dr. Merilind, the stage is yours.
To hear you from Tallinn. We have a very sunny day, and I'm family doctor, and I will speak about family doctor's view of about technologies and how we implement several things and what we have done in Estonia. So what we already have in Estonia, we have digital prescriptions since 2010. We have a picture bank. All the pictures, ultrasounds, X-rays, CTs, MRIs are collected in this picture bank. We have a central system. All healthcare providers are connected to the central system, and we can find all the information about the patient's history, laboratory tests in this central system. We have paper-free practices and hospitals. What are the challenges worldwide? If you look at telemedicine, we are speaking about smartphone sensors, reading the genome, speech recognitions, and virtual augmented reality. You know, Estonia is very proud about the genome project. And we have also some first steps to implement gene data to the patient history and the patient data in family doctor's practice. One very big challenge in the worldwide is the big blue button. This collects information from different online systems and gives a small report, which is very important for doctors, and you can send this report to the specialist and outside of the country. And we have this development already in Estonia. We call it like a description of the health status. And this collects all information about one patient in our family doctor's database. And we will find the most important information. It takes about 1 minute up to 3 minutes to collect all the necessary information. Worldwide challenge is to collect all the patient's information in one account the Microsoft Teams. We had yesterday some big problems with Microsoft Teams. If you are speaking about this personal health account, one big challenge is to collect all the information from the we call like wearables in one database. And TalTech is university in Tallinn is also one pioneer of the developing of this collection to the health data. Sorry about the technology. Speaking about technology, I'm in trouble with technology. So come back to the wearables, how to connect the data from the different wearables. And in this Smart Care project, we collected blood pressure, weight, glucose, oxygen level, and we had also like alert button. We gave to the patient some of the wearables, and we collected the data to one database, and we organized some observation of the patient data in our family doctor center. It was a very nice project, and I hope this would be also continued in the future. We have one very nice project in Estonia also about remote monitoring of patients with sleep disorders. We have a project called TermTest. It's a dermatology remote consultation. We call it e-consultation, remote consultations. We can, in Family Doctor Center, to do some slides or photos about the skin disorders and send it through this TermTest system, this Estonian development, to the skin specialist, and the skin specialist can give to us information what we can do with this test in the future and how we can treat it. When we speak about remote consultations, we have in Estonia a couple of websites. One is MyDoc. The family doctor or the different specialists are answering patients' questions, and you can even order some of the prescriptions in this MyDoc website. One very important website is Viveo Health. Viveo Health is now developing to India, and also gives some quick answers to the patient questions, and connects patients with different specialists. I have my own website also for family doctors, e-consultations, and I give some couple of e-consultation per week for different patients also in my family doctor's practice. The main question is how to stimulate the e-consultations and how to purchase or pay for this. This is a very nice example from the UK. And in UK, they started with a small amount of the family doctors. Then they added money for these e-consultations. They added money for all of family doctors or the GPs, and they made it a mandate. During the COVID disease, all the family doctors should be connected and give a lot of e-consultations. And this, you can see, this is stimulating the number of e-consultations. We have a very nice different rearrangement of patient pathways. One is like eFamily Doctor Center. This is also supported by Norway grants. And this is a family doctor's website. Different family doctors are connected to this website, and you can access or you can book an appointment through this website. You can start your sick leave. You can ask some questions. You can order some prescriptions. You can order some of the health certificates, and all this information is collected in this website. And the website is safe and sure. You should log in to the website with your mobile ID or ID card. We have also some interesting developments in Estonia to change the registration process. And this is there are slides from Harri Longman, and this is a main difference of the Family Doctor Center, I think even in the hospitals registration process. And if we think, usually we start, the patient is thinking, I need an appointment, but the change idea is, if you need the appointment, what kind of appointment do you need? And Harri Longman is saying that all the patient requests are collecting in one assignment point, and there you have, like in Harry Potter's speak about the two major processes also in Estonia is e-registration to find very quickly and very comfortable doctor's appointments. I will speak e-consultation and about artificial intelligence to help the patients and doctors. We have a nationwide digital registration. It's also one door for all specialists. Now also family doctors are trying to connect to this system. You should log in the website. You can find the different specialties. All the specialties in Estonia are in this digital registration website, and you can find free of charge. This is health insurance fund payment, paid appointments, or you can find private appointments. And this would be a big list, and you can book appointment immediately from this website. Yeah, this is very good, and I usually recommend people to find a specialist appointment in this website. E-consultation. E-consultation is a new developing process in Estonia, and we started several years ago with 20 different specialties, and now we have almost all specialists are doing also e-consultations. And e-consultations, we have a lot of for neurology, orthopedics, and endocrinology doctors appointments. But e-consultation is very good for family doctors, because we have here three big outcomes. First outcome is the specialist accepts and takes the treatment over. The second possibility is the specialist will make recommendation for future treatment to the GP. And the third possibility is a specialist will return the referral letter to the GP, because it does not contain the information to make some good decision. And Estonia is now making a lot of consultations but we previously had face-to-face consultations, but now we are doing a lot of e-consultations, and it's good for patients, and it's also for family doctors because it saves patients time, and sometimes we can do some laboratory tests or investigations even before we send the patient to see the specialist. I like it. And the payment scheme is very simple. The Estonian Health Fund pays for specialist consultation to the family doctor, and we pay this for the family doctor from family doctor's reimbursement plan. We are paying these consultations to the specialist. Artificial intelligence is also new in Estonia, and we are in a pilot project, and this is also is changing the patient pathway to see the family doctor. It's a new website, and you can also give some information to the family doctor about your complaints, how long you have had it, have you had a fever, or what kind of medication you have tried before. And this comes to the family doctor's website with different colors, and gives you some idea how quickly we should manage this patient. It gives like a big list. I have closed the patient data, but it gives a big list, and in this list you can sort it out if you can solve the problem the patient by calling the patient, give them video consultation, just prescribe some prescription, or call the patient to see a face-to-face consultation. Fourth, we have a clinical decision support. Also, it's implemented in our family doctors programs, and it collects also different diagnoses to this patient and gives some information what to do to this patient in the future. There are some like guidelines also implemented, and it's in Estonian language, and if you want to find something, there is also some search point inside. We have also in Estonia the database for advice drug interactions and drug interactions. It's also implemented in family doctors program, and gives some alerts if some medications are making interactions, or even if it's contraindicated, we should review before we prescribe the prescription. Other good examples. We have in Estonia like a small chatbot. Chatbot is for alcohol-dependent people, and it's very funny. If you go to the website, the chatbot will talk to you, and you don't want to drink anymore. Video helper for people with hearing impairments. Also, you can see there is a mobile phone, and the translator gives a video consultation, and I speak together with this patient in my room, and the translator helps the patient with hearing impairment. We have speech to text, also Estonian development for Taltech for Android apps, and we have also in website, if you speak something, it will automatically change speech to text. I use it sometimes if I have very long stories to send to the specialist. But in the future, we can use virtual reality. This is not in Estonia, but this is in Silverchain, is one healthcare provider in Australia. And if the home nurse is visiting the patient, she will wear the virtual reality glasses, and all the information are immediately available and even the video consultation is available to the nurse and can give some information and advice. If the patient will wear this the virtual glasses, there is a hologram, and I like it, the idea that you can send hologram to make some home visits instead physical visits, but it's quite rare, hologram. So, and for discussion, I will end, we have for discussion a very big question: how and who should pay for all these services? Thank you for my presentation, and I'm sorry the Microsoft Teams made some problems since the beginning.
Thank you, Dr. Meri Lind. And the next presenter is also here from Estonia, Dr. Mart Kull. He's a medical researcher and general practitioner and board member of Viljandi Haigla, which is a rather big haigla in the center of Estonia. And Viljandi Haigla is exceptional because they include care sector to their services. So, Dr. Mart Kull, the stage is yours.
Trying to open my channels. And am I visible and can you hear me? Someone please nod, maybe Eero. Well, fantastic. Thank you. Also the question about the slides. Do everybody see my slides or not yet? Okay. Let me try to just maybe this will work now. Yeah, just a little bit better than Eero. So, thank you, Eero. Hello, everybody. I'm as introduced. I'm coming from the Viljandi Hospital, and I'm really grateful for the chance to talk about a small pilot project that we started. I will see if my slides they are not going further. Maybe now. So I'm just to declare my interests. I'm a rheumatologist, so not a general practitioner, but I hope that's not a crime. But I don't think I have any conflicts of interest with this talk. So just to give a very short background where we are operating, we are in the Viljandi County, which is quite a small region with a population of around 50,000, and the healthcare system here consists of around 30 family physicians, us, Viljandi Hospital. We have then also 3 private clinics and 3 social or local governments with the social service providers. And we are providing not only local services, but also we have 2 regional services. So we operate outside Viljandi as well, in Tallinn, Jõhvi, Sillamäe, and Narva. Altogether around 600 hospital beds and 1,000 employees, with 80,000 outpatient visits and 7,500 inpatient stays, and our ER does around 16,000 visits every year. So, coming to the distance spanning technology, we ran into a problem. We ran into 3 problems, and one is the main cause, and you probably are all familiar with it, and it's called the COVID. And this caused us 2 other problems. First, some of the elderly patients during the first wave in Estonia were really actually afraid of the hospital, and delayed their hospital visits, and then also even if they came, they were quite late. Sometimes the condition had really deteriorated, so and even then they didn't want to stay in the hospital just because they were afraid that the hospital is where all the COVID is happening. And then there's another problem also related to this, that we ran out of hospital beds at some point, because we really had to use big wards as single wards, and also the hospital outbreaks in the second wave in every hospital, they also restricted our bed numbers. So we really had a problem of having the beds for the patients. So we had a problem. This is protected from COVID, and we went into problem-solving regime and looked at some literature. We asked ourselves if the patient is stable enough and the patient and the relatives do agree, could we maybe provide these patients with the hospital at home service. So this is the distance spanning we undertook. We tried to take the hospital to the home. So nothing new in the sense of global healthcare, because when we looked at the literature, we saw that hospital at home has been implemented or tried in different countries for more than 2 decades now. And the studies show that the quality of care is comparable to inpatient care. The patient satisfaction is actually higher, and the patient confidence with their own care is greater than the same treatment in the hospital setting, which was really surprising. So just when we looked at the literature, we expected a demand of around 100 cases of care in our county. So this is about every 10th patient coming in could be probably treated in the hospital at home setting, yes. And we also, based on the available literature, predicted that this would cause maybe a 10% saving in inpatient treatment costs. And this is actually quite interesting. It's not because it's cheaper, because we don't have the rooms, don't need the rooms, but it's actually the hospital adverse events that cause the cost saving, which is hospital infections and hospital thrombosis, which are more frequent in the hospital inpatient than in the home hospital setting. So some designing and meetings later, we tried to had the preliminary criteria for admitting to the hospital at home. So we chose chronic conditions, which very often deteriorate and they come to the hospital, which are COPD, so chronic obstructive pulmonary disease, chronic heart failure. Also, we considered that some acute and subacute infections can be effectively needing intravenous antibiotics can be effectively treated in the home setting, and also, of course, diabetes or when the diabetes goes out of control. We also needed, of course, the patient-informed consent, but also with this service, family members were really important stakeholders. And also, it had to be not too far from the hospital, because the nurses who visit the patients really needed to get there and back in time. And also the home conditions needed to be acceptable, which later turned out to be quite an important criteria. So the exclusion criteria we also worked out, and these are only very brief criteria in a sense that they are much more detailed in our working materials, because there are a lot of condition-specific criteria when we can and when we can't admit someone with a COPD or diabetes. And so basically the patient had to be stable enough, and there was a low risk of deterioration in the next day or two. So these were, and also a very thorough referral from the referring physician. So this is the care model we came up with. So we came up with actually 3 referral pathways. One is from the ER department directly. So if the patient is admitted to the ER through ambulance and the patient meets the criteria, he or she can be referred to the hospital at home. Also early discharge pathway, which is when the patient is already getting better and is stable enough, then with the same diagnosis, patient can be referred to the hospital at home for further care. And we later also adapted the family physician referral. So family physicians have also now started to referring patients to the hospital at home from their practice, so they don't need to come to the hospital. So very briefly, here it is, the hospital. I don't know if the pointer is, probably the pointer doesn't work, but the nurses, the primary provider in the patient home, and then the nurse is equipped with all the IT equipment. So basically the iPads or smartphones where we are using our own hospital telemedicine portal. So the nurse can bring up the picture, and then the doctor, who's on the lower left, and this is our home hospital doctor, can come to the visit with the nurse and examine, or the nurse is the hands and eyes, and the doctor is basically the brain sometimes behind the visit. So this comes with the nurse to the patient, and the patient is actually comfortably in her or his own home. So this is very, very briefly our model, and some pictures from our service provision. On the right, you can see one of our very, very talented nurses who has been the backbone of the service, and the doctor also seen on both of those pictures. So in the patient home, taking history and asking the symptoms of an elderly male with cardiac insufficiency. So to be clear that this is inpatient service, I'm sorry, mind my technical prowess hiding the patient data, the blue box there, but this is our internal medicine ward weekly round. So during the weekly round, we discuss all the patients in the hospital, but also you can see the same doctor with her patients on the screen. So the doctor herself is also not in the same county. Actually, she's living in Tartu. So she's presenting all her patients, and we all, with the other doctors, discussing and discussing further analysis and investigations and treatment tactics during the weekly hospital round. So basically, this is very similar to the inpatient, and the only difference is that the patient is at home and the doctor goes there through the IT portal. So where we have come, we started it on the 1st of April, so it's April Fool's Day, but it was not what we thought, and we started our first patient on the service, and so far around 70 patients have received, and around 650 home hospital bed days. We have provided with 400 doctor-patient televisits and more than 600 nurses' home visits. Not all visits to the home are the doctor engaged, so it's almost all, and 1 to 2 visits per day from the nurse. So depending on the treatment, if there's 2 times antibiotic intravenously, then it's 2 visits, of course, or infusion. So this is depending, of course, on the care plan. And the team that we have at the moment at our disposal is 1 full-time doctor, 4 nurses, and we are operating with 8 hospital-at-home beds at the moment. So this is the future model. On the left side, we have the same model I showed. This is the hospital at home, but if maybe our Estonian colleagues have heard, we have also been trying to develop the integrated care coordination model. So it's called the PIKE model, where we take also basically the same diagnosis patients and try to coordinate their care, because it's has shown that it reduces hospital stays. So many of the patients in the future probably who go into the hospital at home service also need care coordination. So we are trying to integrate these 2 services, and also the green picture on the top. We are looking for an IT or machine learning model to better predict those patients in our inpatients who might be suitable for hospital at home. So we hope that this the hospital IT system can kind of predict and suggest those patients at the right time to go into the home hospital settings. For instance, if there is an infection and then already a 15% reduction in CRP or inflammation markers, there's a red flag coming up that consider for home hospital, and also those who need care coordination at the county level, so they don't get into the hospital in the first place. So we hope to integrate on a county-wide level these two care models. We'll definitely try to continue providing the service just to get some more experience. We now know what we don't know. We are approaching that state. And also we would like to develop a more standardized referral and inclusion model. And also we really need to assess its impact both on the quality of care and also patient satisfaction. So PREMs and PROMs need to be collected. We are trying to or planning a small scale clinical trial to do that. And in the end, so what are the lessons that we have learned so far? We are really happy. We really needed the service, so we had a strong pull to implement it. So even our weak IT system, which we have at the hospital, I think we have the worst hospital health record system on the planet. I don't think any system generates that many errors per day, but let's ignore that. So you don't really need that much money to start a change, but you really need the money or financing model to keep it going at some point. So you can do some things out of energy and out of optimism, but at some point you really need a sustainable financial model. We were really happy that the elderly people were not afraid to try new things, including the smartphones and the tablets, and especially the relatives were happy, and some granddaughters and sons were really happy to help their grandparents. We were quite surprised how different the living conditions are. So there were some patients who were included in the service, but we couldn't carry out the service because it was so unsanitary that treating an infection in such a situation seemed not to be the best idea. There's still some room for aligning the social care system and the healthcare system, definitely. So there are some services still missing, and how to organize them to support the healthcare that we are providing is still a big challenge. And it really takes a team, which we learned, and we were happy to have that team. And we think that we came a small step closer to a patient-centered healthcare system in our Viljandi County. And we also put down some maybe global or it's not specific to Viljandi, some obstacles and weaknesses and also some strengths and opportunities that we can leverage probably in the future. So what we know or understand is that the fee-for-service model, which is the predominant payment model in Estonia, is not ideal for providing value and value-based healthcare or patient-centered healthcare. So this is probably every system that has tried it will face it at one point. Also, we tried to get funding, and we still don't have funding to further develop this hospital at home. We just got rejected by the health insurance fund. So we looked how much funding does the health system get from our main payer, which is the health insurance fund. So it's around 2 million. I looked at the budget they have and didn't find any other articles. So 2 million accounts for 0.1% of the total health budget in Estonia. So that's really trinkets in the big picture. We also feel that the private sector, who has the capacity to bring new solutions, is a bit far. So our first speaker today said that there's a lab where the needs and the solutions meet. So I think all the innovators in the IT sector, they are not based at hospitals, and so coming from outside, it's really hard to know what are the problems that need solving. So I have quite a bit of friends in the IT department, in IT sector, who come to me and say, Mart, we have solved your problem, and you try this. So I always ask, how do you know that we have that problem? So it could benefit if we're closer, both also physically and in other senses. So the push solutions don't seem to be the best solutions in the healthcare, which is often the case, as I just described, and it's not also the problem with the IT innovators. It's also a problem with the healthcare workers, because we are a really conservative sector, and doctors, we don't like being told how we should do things. So that might be also the issue, bringing change into the system. So some trust issues, I also believe, are there, and it's not about the IT and the healthcare, but it's more about the payer and the healthcare system that it is financing. We often get, when we are going with a new idea to the health insurance fund, that the kind of are skeptical that another hospital wanting some new money, and we are paying already for this, so why should we double pay for it? So we see that there's some trust or mistrust about that. We all do things just because of money. I don't think that's the case. But there are very, very good things as well. I think the funding and the interest in the private sector is strong. And if we can find each other's doors, I think there's very big potential. So there are a lot of clever people in Estonia in both healthcare and IT. So we are quite strong, I think, in that regard. And I also think that the decision makers are now really starting to believe that it's not only the people service models, but more value-based purchasing and IT innovation that will bring the change that we need with the aging population. And although I was giving the talk, I'm really grateful for all the team that has put their efforts in for the past 1.5 years. So Katrin is from the university and a really good analyst and has helped us. And Dr. Mainranu Randaru is the clinical team leader of our project. And Eve Pärnaku and Kadri are the nurses, and Dr. Estrid Cruz is the home hospital doctor, really integral to the service. Kadri is leading the clinical team, and Katrin Kaarma was our also one of our chief executives who brought it all to life, and Triinu, our ER head of our ER department, where the patients are referred to, and Andres has been great help with all the IT and project development. So great many thanks to my team for that. So with this I end, and if there are some questions, I will try to answer.
Thank you, Dr. Kulm. So now it's time for questions and answers. Hopefully, we can find some answers. So actually, I picked up some similar notes from your presentations, and one was really, you all emphasized or brought up this issue of communication. So solution is not only a solution; it also involves the whole process around it. And communication seems to be one of the key elements. And if we think that who are the customers in your cases, so how you overcome this issue of communication, or what are the best tricks or tips how to communicate your goals, your processes, and what you are trying to do with your patients? So we can maybe just start with Dr. Jens Espeland.
Yes, thank you. That has been the biggest challenge, I think, in our clinical work, where we have we followed about. I was working closest to a project. We followed 118 patients for 2 years, and I think we did a lot of wrong things with the beginning. We started with a traditional communication, telling patients what to do, and they don't listen to us. They want to do what's in it. They ask us what's in it for me. And we have to change our way of communicate because we have health professionals haven't learned how to communicate digital with patients. We have a lot of education in how to communicate face to face, and are very busy how to handle that one. But the only competence they have, health professionals have in digital communication is social media. And how do we, and telephone. And we have used telephone for 150 years. And we can't transform those communication techniques to the modern digital technology. And we can't transform that video consultation from the face-to-face communication. And you know, we have been for a year now. It's quite exhausting have a digital communication because you're seeing the face all the time and the eyes to the patient, to everybody in the. So I think what we have to do was to learn from the patient. How do we have to change our way of talking to the patients? And we have to give patients access to our time, and how could we get patients access to communicate on their what's best for them. And we have to adapt the patient's need. That in the traditional way, the patients have to adapt to us. We make the premises, we make the rules. I can talk to you now, you have to call me tomorrow. But when the patients discover that I can communicate with the health professional whenever I want. If I wake up at 2 in the night and have anxiety, and I'm afraid of stroke, but I don't think I have it, but I have to ask the patient. And they knew that the next day they get an answer. And it's about confidence. They knew if I typed that question 4 o'clock in the night, they knew the next day they get the answer from routine. And that was quite a way of changing our way of thinking and how to work. And thinking how can the patients learn us to communicate on the best way. So my experience was I have to look into myself, because I saw the biggest obstacles wasn't the patient. Some of you said that the elderly people are not afraid of technology. The biggest obstacles is my attitude, our health plan. The patients ask for the technology, they ask for the possibility. So I think we are also talking about the technology exists, and we are just talking so much about the integration to our journal systems. I can't use it before all the systems are integrated and always are in function. I think you said the last speech here, how keep it simple. So that's why some of my thoughts about that. So I think it's a way of changing our attitude, the main thing, I think.
Thank you, Dr. Espeland. Actually, I think that Dr. Merylin proposed the next topic for the discussion, and his question was really clear. Who and how should fund this or finance this kind of solutions? Because, yeah, we can talk about saving money or saving time or saving resources, but on the other hand, it also costs a lot, and we need to have a really sustainable mechanism behind the solutions. And I would like to Dr. Mart Kull to share his view how to find money for the solutions like this.
Okay. Thank you for the belief that I can give an answer. I'm not.
Yeah, it's a simple one. Yeah.
It's a really difficult one, I know, because I've been to several roundtables and really there's no. You need some upfront payment to start such endeavor, whichever it is it hospital at home or patient diabetes monitoring, you need some investment. And as I pointed out, the investment funding in Estonia, I think we fund research quite well, or well is not the word, but there's a clear mechanism how you fund research in the university and in the university hospital. It's less clear how we research innovation in healthcare, and I think they are a little bit different things. We have struggled. We have two innovation projects in our small hospital, and I think we really are small on the general scale of hospitals, and it's been really hard to find both. Even the decision makers say that it's both are really important projects and they have important implications to the healthcare system, but they find it hard to have they don't have the mechanisms to pay for continuing the innovation. So that's really interesting. They want to pay, but they don't have the mechanisms to pay for it. So I think there's a problem with the bigger picture probably in the healthcare system, I'm not sure that all the money should come from the healthcare system as well. So we have been talking about pooled budgets. The healthcare and the social care system should put joint money in chronic patient care and so forth. But I'm really not equipped with the knowledge to provide an answer. I'm working in the Praemset, and as a provider, I'm trying to find the loopholes sometimes to start newer or more innovative methods of care provision. But it's really hard. The loopholes are really few or non-existent. as good an answer as I can give.
Mm-hmm. Thank you, Dr. Kull. Also from your presentation, I picked a really relevant issue. It's there should be a solution, problem first, and then you can start finding solution to solve this problem you have. You really beautifully explained it. You can't work like this, that the IT company opens the door of your hospital saying that, hey, I have a solution, find me a problem for this solution. So, and I know that that Health in Norway, you are doing this joint development together with end users. So what is the main issue, or why is that it sometimes happens that the solution comes before than the problem? So do you have a good way of collaborate with end users? Yeah, Tor and Randveig.
Yes, I think this is a big and difficult question. But we have to think more flexible about the financialization. Yeah, you understand what I say? I think I remember what Bjarne Håkon Hansen, Minister of Healthcare of Norway, said when he was starting a cooperation reform. He said, I would claim that a lot of money is spent in the wrong manner in healthcare. And I think he's right about that. We have a lot of resources in Norway. We are very lucky. But we are using them separately. And we have to put them together to get more effect of it. And I think we have to start the discussion, and we have done it in many municipalities in Norway, that the inhabitants have to think about this themselves, to take responsibility for their homes and equipment that make them go up with their lives. And we have to talk about it. It's a difficult question, but we have to start it, because many of them is buying watches, which is medical instruments. Why shouldn't we use it in the professional healthcare? We have to take care of the gap. and we have to put this together. And I think it's possible to talk about it. We are talking a lot about loneliness in Norway these times, specific. And then my mother, she can't operate this anymore. But then we bought a screen for her. I can call her. And many municipalities are buying this to their people. But why don't we talk about sharing? It was her children, me and my brothers and sisters. We bought this to her, and we is cooperating with the municipality to use it. We have to start thinking in another way of financing, because it's a huge pot of resources, and we use them separately, and we use them very often wrong.
I also think related to the sort of problems or the solutions that not only always fit the needs, is that one of the presenters of slides where I noticed that some private sector companies are quite far from the public, and both the hospitals and also the municipalities are quite conservative related to what kind of devices to take in and what to do, and therefore often we see that there is a need for an arena where sort of you can translate. It sometimes feels like two different languages are spoken between the private companies speak one language and municipalities, for instance, or hospitals speak another one. And that's what we are trying to do, to sort of be those translators who can facilitate the dialogue between those two. And then we see that we more easy can find solutions, and also uses the competences in the private sector to solve important issues for public sector. So I think that is sort of a model that I think we will see more of these kind of arenas, and because we need, as you've been mentioning, a sustainable approach to healthcare in the future.
May I have a comment?
Yes.
Yeah. Just a little comment, because I often say we need bigger crises.
Yeah. We have done a lot in COVID.
See what's happened in COVID. Before COVID, the family doctors in Norway didn't use e-communication. In 1 week, they got a text or video, and now when I talk to my colleagues, some of them have 30% of their consultation on e-consultation, and they love it. It's better for the patient, better for the doctor. But it wouldn't happen without the crisis. We didn't want COVID-19, but I'm afraid that we don't see the big crisis in the Western health system. So when I started to work with this for 10 years ago, we were very enthusiastic because of the Bjarne Håkon Hansen, as you mentioned, to change, but it's unbelievably slow. And even now they'd ask, is remote care something for the future? Yes, we adopt it, we have to compare. So it may be controversial to say that, the crisis, but I hope it's other ways to do it.
Yes, may I comment? Never let a good crisis go to waste. I think that's our president who said that. So I can confirm that our hospital also, the rate of change that we could sustain for a short period was 10 times as fast as at normal times. So really, crises are good times for innovations. I think that history has proven it again and again through both the world wars and so forth. But But I like the idea that the first speakers in the beginning said that there's an innovation lab for integrated care. I really wanted to hear maybe more about that, what it is and where it's situated in regard to the hospital and all the other stakeholders that are in the system. So really, and also the question was how to really find the incentive. I think you really need to trust those people working in the healthcare sector, and as I told, there's a little bit mistrust between the payer and the ones doing the work at some points. So if the innovation funding is there, those clever chaps in the healthcare, they will start innovating. We don't need to think that they will take that out as benefits or something like that. So just a system that has 0.1% for R&D is not sustainable. I don't think so.
Is to Dr. Eero Merilinnu. Eero, I'm sorry, this is not going to be an easy one again. So in the first presentation, it was really good example. There was like they described how the coordination between the local municipalities and the primary care level providers, there is basically no coordination. So what do you think, what should be done to make this better? Because we all know that in the center there should be an individual person, a patient, and how we can make this ecosystem working around the patient, not vice versa. So how to include the municipalities better in this work?
We are now in Estonia in a very good position. We had COVID. This also made some changes about the discussion we had before. Then we have a big process in Estonia started some couple of months ago, and this Estonian hospital master plan. And in this hospital master plan, we are speaking also about the primary care changes. And in primary care changes, we are speaking about how to widen the services and primary care level. We don't in Estonia. We don't have a patient coordinator. We don't have a health coach. We don't have an IT specialist for data management. And I think it's a future. We should have much more stronger primary care. And as what Jens said before, I'm also always speaking about the side of the doctors. And in one point, when we're speaking about the doctor's view, we like human touch. It's a human touch. Is if you speak with a patient, it's a face-to-face. You can touch, you can smell, you can even it's human touch. And another side is IT solutions. And we and the doctors, we are all the swinging between IT is good, but human touch is better. This is my ideas for you.
Okay, thank you, Dr. Merilinnu. And now really the question is to all of you. And here in Estonia, we have an advertisement where people are telling in TV how they see the future, like 10 years from now. And there, one lady says that there might be a kind of, I don't know, artificial doctor or something like this, or like online doctor, but for sure, I don't want to use this kind of service. And let me remind you that Estonia is considered as a kind of digital nirvana, that we all use computers. But the lady really clearly says that I'm not interested. I want to see my doctor face to face. So like really shortly, because we're running out of time, where do you see the technology in the health tech field is taking us? Like really? Like what do you see, like in really one sentence? Let's start from Dr. Mart Kull. People are not willing to use online solutions, but still the solutions are there. So Dr. Mart Kull, what do you see in the future?
I hope to see a really more integrated health system that includes healthcare and social care. And I don't think that the digital solutions or distance planning solutions are a goal itself, but they are a means of achieving the integrated person-centered healthcare. I don't see digital solutions as a I don't know really savior of the health system. I think the touch and what you just said are just as important and will never replace. Will be replaced by any IT system.
Yeah. Thank you. Tor and Ranveig from Norway. What do you think?
Yes,
Where the future takes us?
I am an optimistic person and I have knowledge. I think the words that come up is flexibility. If we use this with warm hearts and bright heads, we may free the hands to make room for these meetings that we all want, and use the technology to make over, also to monitor and put the persons and the human beings in the situations that needs a meeting. I think we have no time for this today, and the technology may free this time. So we have to think flexibility and the premises of the patient.
Dr. Espeland, what do you think where the future takes us?
I think the most important is that we get a more diversified service. You don't need to see every patient every time at office. When I practiced, you had to come to the office for anything you had to do. I think we can keep what you say, Eero. Just keep the physical contact for those patients who need it, and then don't use that time for the patients that don't need it. And I think that's for you will never know we are all longing for more physical contact, have been digital for a year. So you need it. You can observe things. So I think that's it's going to be a supplement. And as you know, you have treated diabetes patients. When I was practicing, the diabetes patient, they treat themselves. Giving them insulin is deadly dangerous, but they do it themselves, and they use us as counseling. And why can't we use the same way of thinking for other diseases? We are counseling. The diabetes patient comes to us to the office for a yearly control and when it's needed. And I think that will give us more free time to really help those who need the physical presence of the doctors. And it's also better that the patient can also communicate more with each other, and it's easier for us to get. I think it will it's more fun for us. It's going to be a more fun work because it's more diversified, and you can do a lot of more things in the consultations.
Thank you, Doctor. And Dr. Eero Merilind, your vision.
I think all I told to you about the IT system, the digital registration, the artificial intelligence, all this virtual augmented reality, it comes. Definitely it comes, and we should be prepared how the doctors and the patients' communication will change. And there are two possibilities. It would be much more easier, or it would be much more not so easy. I don't know what is the future, but I think we should adapt, and we should adapt more quickly. And we had recently the discussion about the university curriculum. And when we look university curriculum for the medical students, it's the same curriculum as it was before and in last century. If we want to change and if we want to implement the IT in the medical treatment, then we should change also curriculum for the medical students.
It was really important also to bring in the young generation of doctors, actually, because once I received a question from the university student, like the question was really simple. I have this great idea. How can I implement this idea? So, and it's not an easy answer to this simple question, actually. So what we learned today is that the ecosystem is really diverse. Situation is difficult, but I guess it's getting better. Yes, as you mentioned, the crisis gave us a really good kick in the, what's the name of the place? Like, if you kick in, like, I can't say it all. Like,
kick to the future.
Kick in the butt. Okay, and I hope the future is coming faster than we think. So thank you. This was the end of our webinar, and stay tuned for the next event, and we will discuss about this topic also in the future. Thank you and goodbye.
Thank you.
Thank you.
Goodbye.
Yeah, goodbye.